Hello, everybody. Welcome back to Talk ADHD. So, would you believe it is almost 12 months ago since Andrew, I, and another fantastic chap called Richard Peachy hosted a live Zoom call to address what was then the medication crisis for ADHD meds in the UK. And it was that Zoom call afterwards that led Andrew and I to the madness of an idea of we should probably do that more often. They seem to like that. And here we are. November the 22nd, we published our first proper episode. And for those of you that stuck that one out in one go, congratulations, because it was a biggie. It was almost 2 hours, but we have since been told it was nearly 2 hours of the most complete, the most useful, the most factual, and the most helpful information that those people who watched it and listened to it had ever seen on YouTube about ADHD medication, to the point that it was recommended that people watched it who were learning about ADHD meds, if I'm not wrong. So we're still rightly proud of that episode. And today we're revisiting the topic because there are still issues with the supply of ADHD medication to the UK, but it's changed, and the reasons for the supply have changed, and more importantly, the medications that are now in short supply have changed. So because of that, and because of the questions we get regularly, daily in the Talk ADHD WhatsApp community, which anyone can join. The link is always in the show notes if you would like to join the discussion in there. But because of the questions in there as well, constantly about medication, Andrew has very kindly suggested that we revisit the topic, but in a slightly more, I suppose, directed and clear way to answer some of the questions that we've got from the WhatsApp group, and also some of the main questions and concerns about the crisis, why certain medications are in short supply, and particularly and mostly why it is that when people are told we can't give you medication A, but here's medication B, which on the face of it is the same quote unquote drug, for a lot of people, the feelings and the results don't match their expectations. So brace yourselves. This is an episode, I think, that will bear listening to or watching again, without question. And I also think this will be an episode that will be really useful for anyone who is currently going through this kind of process. Anyone that has been titrated, anyone that's been prescribed, anyone that's maybe just at the start of that journey. This is the information that I hope will allow you to speak to your clinicians, speak to your prescribers with a bit more knowledge and a bit more understanding of when you are told that this is the medication we can get, what it may do differently and why. And we'll talk about perhaps why also those conversations don't often happen as well as they should in our initial appointments. So Andrew, first of all, thank you. I know you've put a lot of work into this, and I know it was something that you were very keen to do, but on behalf of the community, thank you. And secondly, are you ready?
So much to talk about, isn't there? Let's see where we go.
Either way, the information in here is going to be useful. So it would make sense to me, like I just said in that brief intro, to start at the beginning, which is that during summer last year, you as clinicians probably were the first to get the rumblings that there were issues with the supply of certain ADHD medications into the UK. Now, at the time, that was more focused on dexamphetamine and brand names that people would recognize like Elvans. There was definitely a shortage of that, as what we saw in the press. It's what we saw in the news. Almost approaching 18 months on from the actual start of that shortage now, the situation has sort of remained the same in that there's a medication shortage, but also changed from my understanding, because actually Elvans is now pretty much back to full supply, readily available. But what isn't is the medication that, from my experience, most people come to hear about first, which is methylphenidate based and is the brand name Concerta. So is that where we're at the moment? Let's start there.
Okay, so yes, there was a shortage of Elvans. There was a manufacturing issue. They couldn't get enough onto the shelves to get out to people. And I think what happened I don't know, because I didn't do this. Lots of people were switched over because we couldn't get the Elvance so readily, were switched over to a methylphenidate-based preparation. So Elvance is the only long-acting preparation of dexamphetamine. So I think a lot of people were probably switched across. Better to have methylphenidate than nothing. And Concerta is the longest-standing, longest-acting preparation of methylphenidate. There are branded generic alternatives now, but it was a relatively straight switch to go from Elvance across to Concerta or one of the branded generics.
My understanding, it seems to be the case that there's been more of a better the devil you know prescribing approach, which is better this than nothing.
It's better this than nothing, but also the meta-analyses show that around about half of people with ADHD will respond reasonably well to both methylphenidate and dexamphetamine. It's about 50% will have a positive response to whichever one they take. And it's the other half that struggle with some of the issues on either and have to swap to the other one.
Now, I'm going to assume this is in some of the information you'll share going forwards, but in as short an answer as possible, that 50% that don't do well on either or, is there likely to be a very quick and an obvious sign that this is not the medication for you?
It's not 50% don't do well on either or. 50% do well on both.
Right.
Okay. So it's about 70% do well on whichever one they start on. Okay. But of that, so of those 70, 20 would probably not do so well on the other one, whereas the other 50 would. Yeah, does that make sense? So it's
I never was good at maths. Okay.
Yeah,
so based on that,
a Venn
then
diagram for that.
Yeah. That's the circles thing, is it? I know what that means.
Yeah.
Okay, just checking. So, but, all right, going off that though, but would somebody know fairly quick that if they were on the medication that didn't suit them, would it be it doesn't feel like it's doing anything? Because some of the questions that we get are about, why does one make me feel very emotional and one make me feel very blunted? Are we looking at, is it those kind of things that would be noticed, or would it be different?
So there's a lot of variables in that question, but the main answer to that question is when you get to a dose that is reasonably effective and it's doing something, straight away you know whether or not it suits you. Initially, you won't know because it's not strong enough, but that starting dose is really about testing out side effects. It's not about seeing what the effects are. Let's see what this stuff is like for you, and then as the dose builds up, the effects, both wanted and unwanted, intensify. And it's a case of matching. Are the unwanted effects worth the wanted effects? That's what titration is for.
So is this why, though, in this situation where people have been rightly desperate and just, I can't get that med, what's my options, that perhaps they've been given a med that on the face of it more closely matches what they were taking, but they haven't had that opportunity to, I suppose, titrate up again because there isn't that opportunity and it's about what's available? Is that why we're seeing people who maybe aren't having their expected experiences when they've switched to different meds, do you think?
We're probably going to have to refine the terms we're using here because there are lots of different names here. We have all these different names of medications, but essentially there are the two molecules, dexamphetamine and methylphenidate. Yeah. So people who've switched from dexamphetamine to methylphenidate because of the Elvance shortage will have a different experience with methylphenidate because methylphenidate is only a dopamine and noradrenaline reuptake inhibitor.
Yeah.
It's a short-acting dopamine and noradrenaline reuptake inhibitor where dexamphetamine is that, plus also creating more dopamine, so pushing more dopamine into that synapse.
So they would have been very aware of that reduced dopamine production, I presume.
It's not as clear as that. That's what you would think, isn't it? Because Elvance is doing everything methylphenidate does plus something, so it should really feel like everything methylphenidate does plus, but that's not how it feels and that's not how people describe it. Some people feel better with methylphenidate. So it's about considering that there are two different modes of action with dexamphetamine, but that doesn't necessarily mean that methylphenidate is a lesser medication. It's just as effective at increasing the concentrations of dopamine and noradrenaline in the synapse. It just does it in a more refined way by just preventing the reuptake of those neurotransmitters.
So if I put myself in a patient's sort of shoes for a minute, and let's say I've been affected by this crisis and I started on Elvans and now I've got to my effective dose and that's settled, and then now I've had to switch and I've been told I need to switch to methylphenidate, for example. Is there a question, do you think, that would be worth asking? Is there information? Is there a different way of tracking things that I should be doing? Or is it suck it and see?
It is suck it and see. Are you in the half group that is able to get a positive response from both, or are you one of the others? And you can't know until you try. That is often the question I get asked at that first appointment, because I present both. For adults, you present both molecules as options. You can have dexamphetamine, you can have methylphenidate. Which would you like? And it's very difficult to give the depth of information to really help someone decide, because there's no research that says X is better than Y in A and B circumstances, and Y is better than X in C and D. It doesn't work like that. Everybody's different. So there is an element of suck it and see.
Okay. The other thing that's just occurred to me, because obviously we see these two brand names, now I'll go back to brand names rather than molecule names. So we're talking methylphenidate, broadly speaking, Concerta, dexamphetamine, broadly speaking, Elvans, right? The one thing that I've seen to have become more aware of in the past 3 years, maybe it's just because I've geeked out on it, is combining a slow release and a quick release. So having this, and we've spoken about this, like a top-up approach. Now, I've seen that be a combination of a slow release Elvans and a quick release methylphenidate. And I've only just realised that actually that makes sense based on what you've said, because notably they sort of do similar things, but in a slightly different way. But I guess I'm not so thrown by that now. But is that fairly, I don't want to use the word new prescribing, but is that an approach that's developed over time to say this top-up theory might avoid certain issues later in the night?
Okay, so there are about 4 different directions I can go in that question. So I think we could get very complicated very quickly. Let's bring it back to basics, because there's so much confusion about all of this, and it's relatively simple. And I think the mistake that people make is the one you've just made, which is, let's not talk about the molecules, let's talk about the brand names. You just did that, and then how do we add in this immediate release, and what does that actually mean? Let's rewind and let's think about immediate release methylphenidate. Okay, just straightforward Ritalin.
Yeah.
That's the original brand name. There are all sorts of others now, but it is essentially that there is no extended release technology going on. It's just the pure drug, just like a paracetamol tablet from the supermarket is a paracetamol tablet. Yeah. So with those tablets, you take one and it lasts somewhere between usually 2.5 to 4 hours. Okay. How? What's that about? So let's answer that. You take a tablet, you swallow it. It goes into the stomach. It breaks up and dissolves, and then it's absorbed into the bloodstream. Yeah,
right.
It goes through the liver first, and a lot is taken out by the liver. But essentially, you take a tablet, it goes into the bloodstream, and it's that sort of takes half an hour to an hour, and that's because of the mechanical process of that happening. And as soon as it hits the bloodstream, it starts going through the liver and the kidneys, and they're the filters that say this is an unwanted substance, and start clearing it out straight away. Actually, before it hits the full circulation, immediate release stimulants are filtered through the liver first. We've got a clever organic system that kind of guards against toxins coming into the bloodstream. So all blood that's picking up things from the gut passes through the liver first, in order to clean it before it goes into the bloodstream. That's biology.
Right.
But then as the blood circulates, it keeps going through those filters, and those filters, through all sorts of clever mechanisms, remove that, essentially a toxin. It's the body is saying this is not part of the ordinary system, and we want to get rid of it, so it clears it out. When you take an immediate release methylphenidate, about half an hour to an hour, it's in the bloodstream, and at about an hour, it's at the maximum level that it's ever going to reach from taking that tablet. And then bit by bit, the liver clears that away.
At maximum level, you mean in terms of efficacy? It doing what it's supposed to do.
And, chemical concentration. So intensity of effect, intensity of side effects. And anyone that's taken a stimulant that's been effective will know that feeling of the onset of action, building up to being at its peak and then fading away again. Okay? And that's the same with dexamphetamine, immediate release. That's what immediate release means. It's not anything, there's no technology dragging it out or slowing it down. That's why it's an immediate release. So straight away, everything's into the bloodstream, and then the body clears it out. Same for both immediate release preparations, methylphenidate and dexamphetamine. And there are brand names for both of those, but it's just the chemical. Yeah. Then, because it's only typically 4 hours methylphenidate, 5 hours for dexamphetamine, the pharmaceutical industry thought, well, that's inconvenient because you have to keep taking tablets if you want the full day cover. So if we can slow down that process, we can stretch out that effect. Yeah? And that's what extended release does. But it's still methylphenidate or dexamphetamine. It's just releasing it slowly. So there are different ways of doing that. So the one you've talked about most so far has been Concerta, and that is, I believe, that's the longest served long-acting methylphenidate preparation, and it's quite a clever little capsule. I mean, they're called tablets, but they're not a tablet. It's a hard plastic capsule that has 3 different chambers in it, and it's also coated in methylphenidate. Yeah. So it's a hard plastic capsule. It comes out the same way it goes in. You can see Concerta in the toilet bowl. It's like a piece of sweet corn, because it's not digested, but it's coated with 20% of the stated dose, 22% actually of the stated dose on the outside. So when you swallow it, that coating comes off, and that's the immediate release. But then on its journey through the gut, because of these different compartments, the gastric juices go in and fizz out more methylphenidate, and on its journey through, it fizzes more out, and that's how they extend the release with Concerta. However, then along came branded generics who said, we can give a similar effect without using these complex hard plastic capsules. We can make like a gobstopper. We can just make layers that are slowly over time, and as the journey goes through, release more of that methylphenidate. So the difference between Concerta and some of the branded generics, the people will say, well, I've tried Zagetin, Mataride, Delmasart, and it feels different than Concerta. That's because it's releasing the methylphenidate in a different way.
So even though the dosage numbers may match, I know there's bits of difference, but even though they may match, the way your body is processing that dose is mechanically, to use that phrase, different.
Yeah, so all extended release preparations of methylphenidate rely on technically a mechanical process, whether that is this little hard plastic capsule fizzing out methylphenidate, or it's like a gobstopper that's slowly dissolving through the digestive tract. They rely on that. So things like the pH, the acidity of your gut, can have an impact. Things like how fast your gut transit is. So, if you've got IBS or you've had bariatric surgery, your gut isn't performing like a typical gut, then neither are these technologies, because they rely on a typical gut. Yeah. but their whole job is maintain that level. So remember I said that when you take a tablet, that first half an hour to an hour, the levels build up. There's a point at which you tip into medicated, and that is the minimum effective concentration of the drug that you need in your bloodstream to get the effect that we're looking for. Yeah. And the job of the extended release preparation is to keep that level of methylphenidate in your bloodstream for as long as we're wanting it to. We're aiming for it to. So,
okay,
10 hours for Concerta.
But the question that comes to mind then is, if all of those variants of the same drug release in a slightly different way, is that why so many people report feeling notably different on them? This isn't what I'm used to, or it doesn't last as long, or it wasn't as effective, or whatever the variants that's what's going on. It's just that it can't feel exactly the same, even though it says methylphenidate preparation.
Yeah, that's right. So the branded generics were made using a different mechanical release technology, trying to mimic what Concerta did. So Concerta laid the ground for, we can stretch out the effect of methylphenidate over time. And when we do it with Concerta, it sort of looks like this across the day. So then the people who came in and did something different wanted to match that and find ways of using mechanical releases that would, in a typical gut, give exactly the same effect. And for some people, it is exactly the same effect. But for some, that gobstopper dissolves more quickly.
Yeah.
Or, it makes its way through the gut differently. And that is what changes the intensity of the effect. Because if the gobstopper is dissolving more quickly, there's more methylphenidate coming out more quickly. So you're getting a more intense effect. Or if it's traveling through, there's less methylphenidate coming out, so you get less effect.
Okay. Question to follow on from that, to everyone that watches or listens to this, just to think about. How many of you knew that? How many of you were told that, unless you've studied pharmacology or medicines or in any way else geeked out, how many of you knew that may be going on? And following on from that for you, Andrew, in your opinion as a clinician, how many clinicians do you think are really fully aware of that? And how many do you think are explaining that well enough in appointments?
This is something I've talked about for years, because I'm interested in it. I'm interested in the release of these short-acting drugs over time and achieving the effects of that over time. Because so many people, when I started out in ADHD, would say, this medication doesn't work. And by talking with them, it was obvious that it did. It just didn't work when they wanted it to. I've taught in all sorts of settings about this topic because it's so important, because so many people will say, this medication isn't working, we should just switch it. When actually there's a lot to unpack in this medication isn't working. When is it not working? What's it like? At what time of the day is it feeling? If you can tell your clinician, it's great at 11 o'clock in the morning, but at 2 o'clock it's awful. What's the difference? What's great about the great 11 o'clock? What is the awful at 2 o'clock? Though that sort of information should spark an interest in your clinician. It's the same as everything. There's a range of skills, but you can practice with a lot less information than we talk about on Talk ADHD. I don't hold back on any of the science when we talk. I think it's not a secret society. This is information that's readily available, and if people can take it on board, certainly in my clinic, if I feel someone is engaging with the pharmacology and is interested in it or is having some challenges with it, a little bit of teaching and a little bit of conversation about these things can really open up an understanding and start to understand why the medication's not working, because often it is working. It's just not working the way you expect it at the time you expect it to. And understanding the reasons for that can then prevent repetition of the problem when you switch to something else.
Yeah, I get that. I just wonder how many people don't get that information. Not because it's not shared, but because the people who should know it maybe aren't as invested in it as you. And as you've just said, could practice with far less, if you like, practical knowledge, if that makes sense. And so may never think to explain that. And then when somebody presents back in clinic for a review going, this doesn't work, I don't think, might not join. But realistically, when you put this down to brass tacks, what are realistically very simple dots to join? What are you taking? What was it designed to do? How does it release? And now let's talk, you mentioned some really interesting things there about what could affect it, right? So there's a few things. You mentioned acidity. You mentioned IBS. So bowel things. Now, not for now, but I'm very aware in the research I've been doing recently that there are high numbers of people with ADHD with a wide variety of eating disorders, right? And so what if those eating disorders have an effect on where the medication is, how much is in there? You mentioned bariatric surgery could affect it. We've now got discussions, I was watching a documentary the other night about the weight loss injections, as they're called, GLP-1s and 2s, Mounjaro. Now, their purpose is to change the way digestion works in order... Hold on a minute. What happens if I've been taking ADHD meds for X and then all of a sudden I start these injections? There's a chance that will change things, right? But unless you knew that the medication works in X way and you've got that information, joining those dots might not seem obvious. So I think first and foremost, before we go any further, what I would be saying to everyone who's listening to this is it's really important to be mindful of you, of knowing everything that it can affect you and your digestion. And, when you feel full, do you have problems with gas? Do you have problems with reflux? Because what we're talking about is medication, as you say, that interacts with our digestive process that then has a job to do that is based on how it works in the quote-unquote perfect or quote-unquote normal digestive system, which means there's variance, isn't there?
There is variance, and that is what a prescriber should be considering. A prescriber should look at what's already prescribed because that is going to make a difference. So the way the body clears out a drug is often affected by other medications that people are taking. Yeah, so there's a lot to think about with that. When you sign that prescription, you should be considering all of those risks. You should be having those conversations with your patient that you're taking this is potentially going to make this difference to the medication I'm giving you, and the medication I'm giving you is going to potentially make this difference to the medication that you've told me you're taking. That should be something that is talked about. That's what I was taught when I trained to prescribe.
It's a very interesting and powerful 5-letter word that you've just kept using there, Andrew.
It's a horrible word, Matt. It should.
Yeah, well, all right. In terms of ADHD but I'm talking in terms of a good prescriber should be having those conversations with you. Now, to me, that's more ethical based. That's more, the service you are being provided and expecting based. Right, rather than anything else. And again, I would ask the question, and I can look at our WhatsApp group and I can look at all the conversations I've had in mentoring people. I'm not so sure that what should be happening is happening as often as it should be. That would be my interpretation. People's quality of appointment and the quality and the time, I think, is what this comes down to, that is being given to them in appointments to explain and to investigate and to preempt potential issues. I don't think that's happening often enough. It's almost like there's a speed prescribing almost of, I don't mean speed as in quickness, of I only have this amount of time, right? Yes, we think this medication will work. Here's why. There's potential side effects. Report back. There is seemingly a lot of that going on.
So that works to a certain degree. That works to a certain degree, Matt. For a lot of people, that's okay. And we can lose opportunities with one medicine, having not explored it enough, and move on to another one that works better, and that's great, thank you very much, without ever needing to go into the levels of detail that we're talking about. Sometimes the second one doesn't work. And then does the third one not work? And then we're at the end of the line in terms of adult licensing. because there's only 3 licensed molecules for adults. So I think people can end up sort of racing through that nice guidelines algorithm, missing opportunities of with a little bit more time, a little bit more explanation and information, people couldn't have a better understanding of their experience across the day, because they're understanding how that medicine is supposed to typically work and release across the day. And if it's not, then there should be a conversation with the prescriber about why that's not the case, what else is happening. Yes, it takes more time, but how long does it take to deal with no response to any medication on that list? And actually, how many babies have been thrown out with how much bathwater? Because that I find a lot.
I spoke to 2 people last week who are that. You've just described the people I spoke to. That was their experience. I've tried everything. None of it worked. Ever? None of it? Is there anything, And I could look at myself. I fully believed that I was one in 1,000 people who was just tolerant to any strength and preparation of methylphenidate, and therefore stopped taking it because I just thought it would never work. And actually, on reflection, I realised it wasn't that. It's just that Concerta XL for me, even on what I thought was my sort of efficient dose, did not last. Was it 10 hours? You said it's stated as? Yeah. No. For me, it was at best 4 to 5 hours, and then there was nothing. And I got skilled enough to go, no, this is a nothing. This isn't a crash. I didn't know. It was like taking quick release, and I've had quick release as well, right? So, but at that point, I thought, well, there's just no point. This is what I'm not getting half a day's worth, right? And I think that's important, is that had I known more then, I may have gone, maybe it's not the med, maybe it's a me thing.
Well, yeah, in that story, this was about gut motility, wasn't it? This was Concerta going through you so quick.
Yeah.
Because how many of us are stressed, and how many of us have IBS and uncomfortable guts that rush stuff through because it's so uncomfortable because of the amount of adrenaline pumping around our bodies. So of course you're not going to get that little clever technological 3-compartment fizz, because it's already being dealt with by the water board.
Okay, right. So let me just summarise where we're at the moment, because I think this is important for this ongoing conversation. Where we're at in the med shortage has changed. We now have more ready supply of Alvans, dexamphetamine. We have a shorter supply of methylphenidate, notably Concerta and other brand names. We're there. Hopefully what people understand now is that if you are being told we can't get Concerta, but we can get you this, the chances are it will work, but it's being aware that it will work differently in the way it mechanically does its job. So there may be difference in feelings. There may not, but there's that potential. Would that be fair to say based on what you've said?
So where the prescriber is coming from is it's methylphenidate, and it's designed to be very like Concerta. If it's an 18, 27, 36, 54 size tablet, then it's designed to be like Concerta in a typical gut. So they should be interchangeable. And for a lot of people they are. But for some people, because of the mechanism of release, they're not. What's really important to not lose sight of is it is all methylphenidate. So the active ingredient is still the same. It's just the intensity of that active ingredient across time is different. So the differences you're noticing are the variations in the level of methylphenidate in your bloodstream.
Yes. Yeah. Yeah. It's not a different thing. It's just levels of, okay.
It's not a different drug.
No, that makes a lot of sense to me. Okay. So I'm looking at now the questions that I see time and time again that we receive. And in what you've said, maybe because I listen to you so closely, I'm hearing a lot of answers to those. The one thing I just want to go back to is how recent or not is the concept of, okay, there's your XL prescription, but perhaps you need a top-up, particularly for adults. How often or how long has that been happening? And am I right to presume that the same variants may still be at play? So, if you switch your XL preparation, the top-up may feel slightly different because of the things we've discussed as well.
So, first question, how long has that gone on? Pretty much was not in my early days of treating adult ADHD, when adult ADHD was just rolling out nationally. You know, I worked in one of the first adult ADHD services sort of nationally, not the Maudsley one, but as it started to spread out. Back in those days, we would try and not do that. Even while I was still in the NHS, yes, that happened. That understanding that people were metabolizing their and clearing out that medicine more quickly than we were expecting. It would normally be Concerta, and then there would be a top-up of immediate release methylphenidate, because we were seeing that Concerta disappearing, not disappearing down the pan like yours did, but sort of we were seeing that fading out across the afternoon. Pop an immediate release in the mid-afternoon to just extend that through till tea time. That's how I remember it starting, and that's, what's that, 8 years ago?
Okay,
7, 8 years ago. So it's not new, and it's not groundbreaking science really. It's just thinking about keeping the level of the medication above that minimum effective concentration for the time that we want it to be above the minimum effective concentration.
No, that makes sense.
It's not adding another drug. It is topping up the level of the substance that's already in there.
Okay. And then the second part of the question, though, is that bit about, but if we're taking, I don't know, let's say Delmasart, to pick one of the brand names, and it does its job of being metabolized differently, could that then affect how the top-up, which won't have necessarily changed, might feel for someone, in terms of might they feel more, less, etc.?
So the important thing to remember with top-ups is they're what they say they are. They are topping up. So even after you stop feeling the effects of the stimulant medication that you've taken in the morning, and that's fading away, and I need to top up, you're not starting from the same place as you did at breakfast time. There is still a residual level of the medication sitting under the minimum effective concentration, which when you top up, that level sits on top of. So you don't start, if you take a 10 milligram immediate release top up, it doesn't feel like 10 milligrams because there's still some of the 54 milligrams that you took in the morning.
Yeah, that makes sense.
The tail end of that, even though you're not feeling it, it's still in your bloodstream. And when you add in that 10 milligrams, it lifts it so that it can feel more like, well, I wouldn't like to say because it varies from liver.
Hi, folks, it's Matt. Sorry to butt in, but I'll be really quick. It would really help us if you could take a minute to do a few things to help this podcast reach more people. Wherever you're listening, if you could like it, assuming that you do, if you could subscribe wherever you're choosing to listen to this or watch it, and if you could jump onto the YouTube link and leave a comment about the episode that you've just listened to, Andrew and I would really appreciate it, because that all really helps this podcast reach more people. For now, I'll stop waffling on and we'll get back to.
Okay, now I'll come back to some of that in a minute, but that almost answers one of the most common questions is we get asked, how does the splitting the dose of extended release preparations work? And that really means how do people are talking about the extended release and a top-up, and the questions are, what does it do for overall focus? Might it affect sleep? Your answer is exactly that, isn't it? You're not starting from nothing when you take your top-up. You're starting from something still there, and it's about how long it takes your body to metabolize all of the XL. And I presume in terms of sleep, how late you are choosing to take the topper may also then affect that feeling of what people perceive of, and this was going to be the follow-on, that perception of crash, right? Which, again, when we first spoke, we discussed this as it's not really a crash. Crash never felt like the right word. For me, it was I'm just getting back up to full speed. I've had this lovely day of medicine doing what it can do for me and helping with my focus and my attention. And then as it leaves my system, that's when I would feel like different again, and a bit racy thoughts and a bit, as I describe it, a bit more ADHD, but not. I understand why it can feel like a crash, because it can feel for some people so different. But that again makes sense, that there's no standard for when the crash will happen, how the crash will feel, because there can't be, can there?
Well, no, because it depends on how quickly your body is clearing it out. I will take you to task on the crash, though, because that's your experience. But lots of people, myself included, the crash is very, very real. And what the crash is that shift back underneath the minimum effective concentration. So you're describing that return of ADHD type thinking, yeah?
Yeah.
On the journey to that, some people experience absolute just detachment and zonked. I have to sleep. I can't function. I can't think. I just need to stop.
Which is why for them it feels like a crash.
And that, you know, the first time it happened to me, I was like, okay, it is real. So I think people's experience is very different. My experience is the crash is worse when I've had a more stressful day. And other people say that, but there is a shift biologically from the therapeutic range back under that minimum effective concentration, where you're not getting that dopamine transmission that is regulating those ADHD symptoms anymore, and back comes the ADHD, and that's disorienting.
Note then, I wonder if that's why one of the other words I hear a lot when we talk about meds, both when we are adjusting to what it feels like and when we perceive they're clearing, is people talk a lot about feelings of heightened anxiety, and do they cause more anxiety, or why do I feel more anxious? And I wonder if that's got something to do with that journey as well, between what the meds are doing, how we're metabolizing them, the different preparations, and then that returning to below.
Anxiety is a very interesting word, and you can apply it to all the different phases of the effects of ADHD medication. You can get anxious because you're more focused. Lots of people, when they start ADHD medications, experience heightened anxiety. It's listed as a side effect. Yeah. Is it a side effect, or is it actually, wow, I can concentrate? What the hell do I concentrate on? And that creates the anxiety because it's unfamiliar.
I've never done this before.
Yeah, I've never done this before.
Yeah.
Just as much as, whoa, I feel really zoned out. I feel really sort of woozy and distant and sleepy. That's anxiety provoking. It's different. And what stimulants bring is difference, and that difference changes across the day, and it must be managed well. You know, a good prescriber can manage that level above the minimum effective concentration all day. If need, you know, we can also manage it so that there's a dip. If you're not eating well at lunchtime and you need to, then we can manage a dip. So it's thinking about. So when I'm prescribing, I will always take a two-stage approach. I will always start with any stimulant. Let's find the amount of dose that works for you 2 hours after you take it. First step. Let's not aim for, let's sort your whole life out and sort out all the doom piles and the clutter in the cupboards. Let's not do that. Let's just see, 2 hours after you take it, is it giving you the level of focus and concentration that you want? Because if that's the case, then it's working. Then we can apply the science and understand how to stretch that out across the day, or how to give you those peaks. And that is tailoring your treatment to your liver and your metabolism. Not
the question that just came to mind there was, the 2 hours thing makes perfect sense. Do you believe, do you see in clinic that people sometimes get to a point where they will say, I don't think the meds are working, but what they mean is, I'm not noticing the big bushes, crescendos, but if you drill down and say, yes, but how is the focus? How is the concentration? How is what? They'll say, oh, actually, it's better. But it just doesn't. They've stopped registering that the meds are doing something, but they still are. Does that happen?
Yeah, it never ceases to amaze me how many people talk about motivation from their medication. ADHD treatments aren't meant to be giving you motivation. But there's this sort of interpretation that, oh, it's a stimulant, therefore it must stimulate me into activity, which is a complete misconception of what we're trying to do. But lots of people think, oh, well, if I measure my motivation, that is an understanding of how well it's working. And your motivation has nothing to do with the effects of medication, other than because you're more able to focus, you're not as distractible, it's easier to be motivated and start to see results, and that feels good. But that is not the same as, you know, we talked last week about going down the railway arch with the glow sticks, and maybe and it's that we're not looking for that head change. And at first, it is a bit of a head change when you start with ADHD treatments, and it can feel strange, and sometimes people mistake that for the effect, when actually that's the effect of difference. And when it becomes more familiar, that you just know where your car keys are, these strange things start happening, and it becomes more routine. That can feel like the medication stopped working. Well, no, actually, you're getting used to it working.
Yeah, it's not that it stopped.
It's doing anything less, because once you find that minimum effective concentration and you keep people above that level, it will work.
I suppose I'm jumping backwards a little bit, but there's a question I think I wanted to answer, because I've seen it asked all over the place at the moment. Knowing that currently it's Concerta and methylphenidate, preparations that we're struggling with, that's where the shortage is. So we're seeing more people who are being told, well, Elvans. If they are among those people, and the Elvans, for whatever reason, that dexamphetamine does not work, and it's not, you know, they don't get to an effective dose, and they don't feel the things they're looking for, or not notice the things. What would you say would be the option? Is that then, okay, we now have to look at non-stimulant options? And actually, in terms of availability, have they been affected because of the crisis as well?
So why do you keep asking me 3 or 4 questions at once, Matt?
That's the way I'm ADHD. Did you know I've got ADHD?
Is that what it is? Okay. So first and foremost, yes, there are shortages of some methylphenidate preparations. However, there is always an alternative methylphenidate preparation. I've not had to say to someone, I can't give you methylphenidate, so long as you factor in everything we've talked about. The release profile is different, and there are more on the way. You know, the enterprising pharmaceutical industry will be, and you know, I'm aware of a couple more coming to market that are very, very similar, but you know, the demand is there. So I think there will be more of these products becoming available. It is possible to switch, not just between things like Delmasart, Mataride and Concerta, which is, you know, I've been writing those prescriptions as methylphenidate modified release, and allowing the pharmacist some flexibility on that, because there's so much chopping and changing in the availability. Just last week, Zagetin 18 milligrams have started to come back into the country. I think what people underestimate the impact of the fact that we import all of these medicines, principally from the continent. You know, they're coming from Germany, they're coming from Austria, some from Ireland, and there are choke points there, getting those supplies just into the country, and that existed before the Elvans shortage. You know, for years that's gone on, and that is the effect of the increasing demand because more people are being diagnosed. But that's kind of been predictable. The Elvans shortage was an extra bump in the road. But it is possible to switch people over to other extended release preparations of methylphenidate if you think about the metabolism of those and the release profiles of those other extended release preparations that are often more widely available, and you can get a similar effect. You can achieve a similar effect curve if you understand, once you've found, as a prescriber, once you've found that effect and you're understanding how that level is being maintained across the day, it is possible, with a little bit of thought, to think about how to achieve that with other preparations.
Right. Again, it comes down to knowledge and experience a bit, though.
Yeah. I can't get Concerta, I have to give you Mataride. Yes, that is sort of very top level thinking, but actually, okay, there's none of these, you know, there are no 54 milligram tablets anywhere of anything, and that has happened over the last few months. How can I meet that 54 milligram effect across the day with other preparations of methylphenidate?
So can I just go back to something that you just mentioned you do, that I think is a question, can I ask my prescriber to do this? Which is, you've said you've been writing prescriptions for methylphenidate extended release X dose, to give a pharmacist flexibility. Now, I'm still hearing people who've been written a prescription for, let's say, Concerta 56 milligram, and the pharmacist says, can't do that, ain't got any, pal, and then they go into panic mode. Would it be sensible to be asking our prescribers at the moment to right as you are to say, can you just prescribe the methylphenidate extended release?
So there are a lot of caveats to this, but essentially, yes. With that family, the 18-27 family, they're largely interchangeable. For some people, fast gut transit, those sorts of issues, it doesn't work that way. Where problems can occur is with the units of 10. Methylphenidate modified release 30 milligrams, for example. The pharmacist has too much choice because there are different variations of how much you get immediately and how much is extended release in the 10 units. So Medicanet XL will give you 50% straight away and 50% across time, as will Methylphenidate XL in a different way. But if you got 30 milligrams of Equisim, you'd only get 30% straight away and the other 70%, so you'd have more at the tail end of the release. So it's unwise for a prescriber to write methylphenidate modified release 10, 20, 30 milligrams. But for the 18, 27, 36s, they are largely the same.
But I'm going to go back to that statement I'll make again. Is that not, as the people, the patients, clients, call us what you want, is that not us being reliant on our prescribers knowing that in the first place?
Yeah. It is, and as a prescriber, I don't like doing it. It's called prescribing generically. So you write the drug name, extended release, and you leave it to the pharmacist to choose. That relies on the pharmacist choosing. So I don't know necessarily when someone gets in touch and said my tablets aren't working as well this month, if I've written modified release generically,
what they've taken,
whether they got Concerta or they got Zolpidem or they got Madaride, I have to ask that, and then I can say, well, this is why. So from a prescriber's point of view, it's more comfortable to write the brand name because then you know exactly what someone's got, because there are these subtle variants between different preparations. But when you can't get a hold of it, sometimes one of the others does well. Lots of people have been switched to one of the others and said, that doesn't feel the same, I don't like it, don't give me that again. Fair enough.
But this is where good reviews are important, and I guess being asked the right questions or being able to give the right information is important. About when you say it didn't work, what do you mean? When you say I didn't like it, what do you mean? Having the faith, I suppose, that the prescriber you're sat in front of is going to give you the time of day and has got the knowledge to understand and to translate what you say into that could be because, and this is the option that we can take from there.
Or because not all ADHD specialists have been doing it as long as I have, or having the professionalism to say, I don't know, but I'll look into that for you. Because all of us have a supervisor that we can talk to and that's got more experience. That's how this works. Hey, supervisor, such and such said this, and I don't understand that. There's a learning opportunity.
Yeah, of course.
Yeah. So don't be shy to ask questions, even if your prescriber isn't as long in the tooth as I am in terms of prescribing these medicines, because they will have access to someone who is.
We're going to leave that right there for this episode, and we'll be back next week with the second part of this discussion, where Andrew discussed more about how patients can have advocacy over what medication means to them, about how to communicate with your prescriber, and about the things that Andrew as a prescriber would really love us as patients to be saying to him that could really help everyone understand what the right medication for us is. So if you've enjoyed this episode, please do leave us a comment, tell us what you've got from it, and remember, the more people that you can share these episodes to, the more people that benefit from this information. We'll see you again next week.